I'm a radiologist from Graz, Austria, and I am very honored that I can be the moderator here of session 2 on clinical applications. And this is really a cast of all-stars here. Our first speaker will be Professor Paul Barisel, who is the chairman of the Department of Radiology at the Antwerp University. He is also the designated David Hartley Chair of Radiology of the University of Western Australia in Perth. Professor Barisel is one of the most renowned neuroradiologists in the world. He is an honorary member of the European and American Societies of Neuroradiology. He has been the president of the European Congress of Radiology, as well as the European Society of Radiology, and he is an honorary member of the Radiological Society of North America. Our second speaker on chest will be Professor Hans-Ulrich Kautscher, who is the chair of radiology and the medical director at the Clinic of Diagnostic and Interventional Radiology in Heidelberg, Germany. Professor Hans-Ulrich Kautscher served as the president of the European Society of Thoracic Imaging and the Fleischner Society, and he's also the director of the German Center of Lung Research. Our third speaker is Professor Marco Francone. He will talk about cardiovascular. Professor Francone is a regular at European School of Radiology events around the world, and he's in the executive committee of the European Society of Cardiac Radiology, and he is the leader or director of the working group of cardiac imaging of the Italian Society of Radiology. Our fourth speaker will be Professor Daniele Regge, who is the director of the radiology unit at the Candiolo Cancer Center in Torino and an associate professor of radiology at the University of Torino. Professor Regge is the past president of the European Society of Oncologic Imaging. And last but not least, our speaker on breast imaging will be Dr. Albert Gubern-Merida. He's from Spain originally, but he's currently working in Nijmegen in the Netherlands, and he's the head of research and development at Screenpoint Medical. Ladies and gentlemen, please welcome our cast, and specifically join me in welcoming our first speaker, Professor Paul Barisel.
Thank you very much, Mr. Chairman. Good afternoon, ladies and gentlemen. We are going to switch gear, and we're going to be talking about clinical applications, and I have the great pleasure of starting with neuro. I have a few disclosures to make. These are my disclosures. I've been involved with some of these applications for a number of years. When I was trying to structure my talk, I was thinking, how can we do that? And so this is the outline. We're going to be talking about detecting the invisible. We're going to be talking about detecting the visible, characterization of lesions, workflow integration, and then try to reach a few conclusions. And we're going to start with now you see it, now you don't, which is detecting the invisible. In stroke, we know that when we do a non-contrast CT of the brain, that there are very subtle changes in the density that we may not actually be able to see with the naked eye. And when we run software, we can actually identify these small changes, which are invisible to the naked eye. There's an application now that allows people to actually characterize the aspect score, and the aspect score is a very valuable tool for clinical decision-making and patient management. Detecting the penumbra and the collateral circulation in patients with acute stroke is challenging. So far, we've always done that with angiography, looking at late refilling of vessels. We can now do that with CT perfusion and with CT angiography, and we can offer maps that identify the core of the infarct, the penumbra, and have a prognostic factor about the outcome of the patient by looking at patients with good collaterals who have a better outcome than patients with poor collaterals in whom the outcome is much more guarded. My second point is apparently a contradiction in terms. It is called detecting the visible. Why would we have a problem with detecting the visible? Well, let me try to explain you that we are basically, on a day-to-day basis, finding the needle in the haystack. And when I trained as a radiologist, we were taught to identify patterns, to look for specific diseases, to look for specific images. Now, if you have an image like this or a data set like this, it can be much more difficult to identify the abnormality. And all of you who are radiologists have immediately seen that the abnormality is right here. Now, this is how radiology was 10 years ago, 15 years ago. This is how it is today. We are looking at multiple data sets, and we're being asked to identify multiple abnormalities, and we don't know what we're looking for. We don't know if there's an abnormality there. And once you have seen it, this is blatantly obvious. And then you will have discussions with the chair of the emergency room department that will tell you, well, your radiologist missed a small amount of subarachnoid blood. How is it possible that you missed this? Even an idiot can see that. It's easy to see it in retrospect. It's not so easy to see it when you are dealing with large amounts of data. And this is an example of what we use in my department. These are 4 different scans in patients coming through from the emergency room, and the question is there something there? And when you look at the annotated images, you will see that there are small amounts of high density indicating intracranial blood. This is actually helping the radiologist to process these images. Here's another example. This is a non-contrast CT, and what's important here is that you see the workflow and the timing of the workflow, so there's barely 10 minutes between the acquisition of the image and the report, and here's a very subtle abnormality, and we use the same kind of software now since about a year for detecting small hairline fractures of the cervical spine, and you can see this here. A non-displaced facet joint fracture is something that is easy to miss in a polytraumatized patient that you have lots of images to process. So my third point is, hello, my name is, characterization. Can we do that? And we've learned in the previous session that when we start from an original image, we can segment an abnormality, we can reconstruct this in 3D, and we can volume render it. And then if we are aware that the software recognizes patterns, segments mass lesions, and may help to characterize brain tumors, in some cases, this is what the tumor will tell you. And in this case, the tumor tells you, hello, my name is a medulloblastoma. Is this useful? Maybe not for an academic experienced neuroradiologist, but maybe it is useful for somebody in the beginning of their career or not used to seeing these kinds of tumors. And this is actually software that was developed, and you start from analyzing the images, and these images are then compared to the data from Tiantan Neurological Hospital in Beijing. This is the biggest neuro hospital in Asia, 2,400 beds, and they have validated the data against more than 50,000 pathologically confirmed data from tumors, and there you can actually identify tumors in different patterns. Is it 100% correct? For sure not. But in China, there's a dire shortage of radiologists. There are too many data being produced, and they don't have enough people to process everything. So this can be very useful, and this is characterization. They had, about a year ago, and I wrote on the website of the European Society of Radiology, I wrote about this. It was a competition between physicians and artificial intelligence. And as we have heard in the previous session, the artificial intelligence won and had a higher sensitivity and specificity in detecting tumors than a group of highly trained specialized neuroradiologists. And this is something that we have to deal with in the future. My next point, and this will be the point that I will spend most of the time on, is to measure, is to know, quantification and monitoring. And we've been doing that for a long time. And a number of years ago, I was working with one of my PhD students who is here and whose images I will be showing you. To measure is to know. When we translate this, actually what we mean is to segment, is to know. We've seen in the previous sessions that we can segment CSF, gray matter, white matter, and whole brain tissue. Now, if we apply these segmentations in patients with multiple sclerosis, we can actually identify the lesions, we can measure the volume of the cortical gray matter, feed that into a computer, and come out with a sort of quantified, annotated data set indicating the white matter lesions and the volume of the cortical gray matter based on tissue segmentation. And this allows us to make these kinds of reconstructions where from an original data set we can segment out the white matter lesions in the periventricular, the subcortical region. We can actually make a 3D volumetric reconstruction giving the volume, the total volume of white matter lesions and how to deal with this. And we can use this when we compare reports on a previous scan to a current scan to overlay for the gray matter the T1 and for the white matter lesions the flare. And we can sort of transmogrify that into a quantitative report indicating the amount of lesions, the amount of atrophy of the brain, and how the brain is evolving under therapy, and get a sort of fully automated parametric report on the MRI scan. This is, in greater detail, the kind of reports that we think are going to be used in radiology in patients with multiple sclerosis. So you have here
bank gives you 4%,
scan, which is the big bar, and you compare this to the previous scan and to the previous scan, and you measure the volume in milliliters of white matter lesions, and you can do that for different anatomic regions, such as defined by the McDonald modified criteria, periventricular, juxtacortical, infratentorial, and deep white matter. There is an expression in English that says, if you have a new hammer, everything looks like a nail. And this is exactly how segmentation works. Segmentation, once you have the technique to segment out lesions, you can use that to other applications. And in this case, for patients with traumatic brain injury, you can teach the software to actually identify different types of hemorrhage, and you can automatically segment different traumatic lesion types, calculate the volume, the effect, and whatever. Interestingly, one of the most low-hanging fruits in terms of segmentation or quantified measuring is to measure the midline shift. Midline shift is a very good predictor for eventual outcome in patients with trauma. But if you ask 5 radiologists, you will get 7 different opinions. And software allows you to actually calculate the midline shift always in the same way. And in this way, reproducibility is more important than absolute truth. So it could be that you make a small error, but if the error is reproducible and you follow the patient over time, that is more important than absolute truth. And we also make these reports, and just to show you that the world is changing, we were using these reports in a paper that was just published about a year ago in Lancet Neurology on the Center TBI trial, where imaging in trauma patients was done using segmentation techniques and these kinds of midline shift measurements. A third example is looking at hippocampal atrophy. This is very important in patients with Alzheimer's disease and other dementias. And here I'm going to show you very quickly 5 different patients with detailed images showing the temporal horns and the hippocampus. And the question to each and every one of you is this a normal hippocampus or is there atrophy? So this is patient 1. This is patient 2. Ventricles appear a little bit bigger, but is the hippocampus atrophic? This is patient number 3. This is patient number 4. And this is patient number 5. And now, if we look at these 5 patients, we can actually measure the volume of the hippocampus, and we can define somewhere a threshold. And in green, we have indicated volumes of the hippocampus that are more or less normal. and we can segment out even the different sections of the hippocampus. And again, absolute truth is not the most important thing. The most important thing is reproducibility, always be able to have the same kind of results with the data. My next point is making the wheels go round, workflow integration. And those of you who were present when we had the discussion at the end of the previous session heard a very important statement being made. Where will the big impact of artificial intelligence be? Will it be in image interpretation or workflow? Well, I also believe that it's going to be workflow integration. And workflow integration means a number of things. In our department, since about a year, it means that when you automatically detect acute findings, you can actually prioritize the work list, and so you have work list assistance, and then moreover, you have help to the radiologist in identifying subtle lesions, which is reading assistance. And ideally, you could develop a work stream where you have the information available to the radiologist, for example, on a cell phone, communication. In patients with acute stroke, you could automatically send the parametric maps or the perfusion maps to the doctor on a cell phone, who can then decide whether to intervene or not to intervene. So this is really, for patient triage and clinical decision-making, very important. Finally, the future's so bright you gotta wear shades, or maybe not. And here, I've listed a few things that I believe that artificial intelligence today is doing for neuroradiologists, what it can do to help. And here are my points. So detecting subtle changes invisible to the human eye for stroke imaging. Processing huge data sets, making the visible better visible, making sure you don't forget anything, making sure you don't forget the small amount of subarachnoid hemorrhage, the small subdural, the rib fracture, the pulmonary embolus, or whatever. Characterizing rare brain tumors. It works best for rare tumors. Everybody, every one of us can recognize a meningioma, because in our lifetime we've seen hundreds, maybe thousands of meningiomas. But in my entire lifetime, I may have seen only a few cases of choroid plexus carcinoma. And there, if you have software that can actually access the encyclopedia of hundreds of cases with this rare disease, your software will be better than the experience of one individual. Quantifying abnormalities, we show that in multiple sclerosis, in traumatic brain injury, in hippocampal atrophy. Helping to monitor disease, helping to detect whether actually a medication that is very expensive, a monoclonal antibody, is helping or not. Unraveling relationships in population studies could be a step for artificial intelligence. And we see now that already today we have applications for multiple sclerosis, dementia, stroke, brain trauma, and whatever, and there's a number of other regions being developed. This is a workflow that was designed by Dr. Hugh Harvey, going from the patient record to eventual communication. I don't have time, but this is in the literature. There's a few caveats. Results must be carefully checked and verified. Segmentation could be imperfect and could be erroneous. Tremendous amounts of annotated medical images are needed, and that takes time and energy and money. Integration into the workflow is essential. You cannot have a standalone AI system. There is no point in that. And finally, clinical validation of AI will need rigorous controlled studies. And so I think that with AI, we are moving from black and white TV to color TV. We're adding a new dimension to what we do. And I am a strong believer that this is going to make radiology more accurate and help us, and will not be a threat. And with this, thank you very much for your kind attention.